Okay, this is part 2 of urinary physiology. So tubular reabsorption, again, this is reabsorbing back into the blood from the filtrate, okay? So everything in blue here is what's reabsorbed, okay? So this happens via 2 routes, the transcellular route, which is where the solute can enter the apical membrane of tubule cells, travel through that cell, and exit via the basolateral membrane of that cell, and then enter the blood through the peritubular capillaries, or the paracellular route, which is between tubule cells, and this is limited by tight junctions, so only small things can happen here, okay, or can pass through the paracellular route, okay, so this would be like water and those ions, okay. So basically, transcellular reabsorption is directly through the cells of the tubule, and paracellular reabsorption is where fluid kind of leaks between the cells. Okay, you don't need to know those in too much detail. Okay. Okay. Okay, so sodium, how does sodium move across the basolateral membrane? Sodium moves via primary active transport. So it needs ATPase pumps, and that pumps the sodium into the interstitial space, and then it's swept via bulk flow into the peritubular capillaries that would be surrounding the tubule here. Okay. That sodium reabsorption by that primary active transport mechanism gives the energy for reabsorbing almost all the other substances. Okay, so secondary active transport is when glucose, amino acids, the other ions, and vitamins are co-transported along with the sodium. Okay, so even if they're moving against their concentration gradients, they can move along with the sodium. They kind of like jump on its back, not really, but and travel along with it back into the bloodstream. Okay. Water is reabsorbed passively. Okay, so wherever sodium goes, water wants to follow. Okay, so this is why so much water is reabsorbed in the descending loop of the loop of Henle, because as we move down into the medulla area, it becomes saltier and saltier, so that water is just following that sodium. So that's how water moves out. Okay. As water is reabsorbed, the solute concentration in the filtrate is going to increase, right? There's going to be more solutes compared to water because the water is all leaving the filtrate here. Okay, so this creates a concentration gradient for these solutes, and that drives their entry into the tubule cells and the peritubular capillaries. Okay, so they're going to move out along with water. Okay, just along their concentration gradient normally, kind of like diffusion. Okay. So this happens with fat-soluble substances, some of the other ions, and urea. Okay, so they'll help to follow water as well. Okay, so lipid-soluble drugs and pollutants, these are reabsorbed. Okay, because they follow the water, they go down their concentration gradient because water is leaving. Okay, so even though it's not desirable, it does happen in the body. Okay. Okay. Now we have water also being reabsorbed in the distal convoluted tubule and the collecting duct there. Okay, so this only happens at this area. Most of the water is reabsorbed here in the descending limb. But if it's happening in the distal convoluted tubule and the collecting duct, that happens because of the presence of ADH, antidiuretic hormone. okay? So a diuretic makes you pee more, but an antidiuretic, like antidiuretic hormone, makes you pee less because it's conserving water back into the blood. Okay, so I just wanted to point that out there as well. Okay, so that water reabsorption is regulated by ADH. Okay. Okay, so let's kind of start going through here what is reabsorbed where. Okay? So, starting in the proximal convoluted tubule here, ions, bicarbonate, water, amino acids, glucose, and urea are reabsorbed, okay, into the bloodstream. Now notice we don't see glucose anywhere else. All of the glucose that we need is going to be reabsorbed at the proximal convoluted tubule, unless we have too much glucose in our blood. If we have too much glucose in our blood, this can indicate diabetes. And that's why in diabetics pee out a lot of glucose, because there's not enough time for the proximal convoluted tubule to reabsorb all of the glucose if there's too much glucose in the blood. Okay, so that's something important to point out. Okay, now in the descending limb of the loop of Henle, again, that's where most of the water is going to be reabsorbed. Okay, especially if we're dehydrated, then more and more water is going to be reabsorbed, and that helps the other solutes to be released as well. Okay, in the ascending limb is impermeable to water, so water cannot move out or in. Okay, so we're going to have our ions. I wrote all the ions here, so sodium, potassium, chloride, magnesium, and calcium. Same thing here, those are the same ions. Okay, wherever I wrote ions, I'm talking about all of those. Okay, so ions are going to be reabsorbed into the bloodstream, and more bicarbonate is going to be reabsorbed into the bloodstream at the ascending limb. At the distal convoluted tubule, some more water if we're dehydrated, bicarbonate, and those ions. And then in the collecting duct, not all of the ions, only sodium, chloride, bicarbonate, water, and urea are reabsorbed. Okay. Okay. And remember, water only if we're dehydrated and we have ADH acting. Okay. Now, what is secreted, which means put back into the tubules from the blood? Okay. So at the proximal convoluted tubule, ammonia, drugs, hydrogen ions, creatinine, uric acid, and urea are secreted back into the tubules. In the descending limb of the loop of Henle, urea is pushed back in, is secreted. Ascending limb, nothing. Okay, we only have reabsorption in the ascending limb. Distal convoluted tubule and collecting duct, we have ammonia, drugs, and hydrogen ions being secreted back into the nephron. Okay. Okay. Okay, so we talked about angiotensin, we talked about aldosterone, ADH, and AMP. We didn't talk about parathyroid hormone. So parathyroid hormone is triggered by a decrease in the plasma calcium level. When there's a decrease in the blood calcium level, this will cause release of parathyroid hormone from the parathyroid glands. Okay? And it increases reabsorption of calcium. Okay, so that calcium is reabsorbed in higher amounts into the bloodstream. So that's part of our ions there. Okay, so that's another hormone that you should understand. Okay. All right. Okay, I'm just going through. It's giving summaries of all the stuff we've already talked about, so I'm just passing through on the PowerPoint, seeing what else we need to talk about, okay? Okay, secretion, we talked about that. Okay, so how do we regulate the urine concentration and volume of urine, okay? We have two different types of countercurrent mechanisms. So first we have the countercurrent multiplier. This is the interaction of the filtrate flow in the ascending and descending limbs of the nephron loop of the juxtamedullary nephrons, okay? And then the countercurrent exchanger, this is blood flow in the ascending and descending limbs of the vasa recta, okay? So they both work together to maintain a medullary osmotic gradient from the renal cortex through to the medulla, okay? So it runs from 300 milliosmol in the cortex all the way up to 1200 milliosmol at the bottom of the medulla, okay? So the countercurrent multiplier creates that gradient, and the countercurrent exchanger helps to keep or preserve the gradient. Okay. And then the collecting duct at the end of the loop there can use the gradient to vary the urine's concentration, right? So it can cause reabsorption of more water if we're dehydrated, as an example. Okay. 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 So in the juxtamedullary nephrons, the nephron loop is very long, right? We talked about this in the anatomy video. This is what creates that gradient. So they act as the countercurrent multipliers, okay? So the osmolality, this is the solute concentration of the interstitial fluid in the medulla. That is what progressively increases from 300 down to or up to 1200 milliosmol as we move deeper into the medulla. Okay. The vasa recta, which is the capillaries that surround the juxtamedullary nephron, those preserve the gradient. Okay, so they're countercurrent exchangers. Okay. And then the collecting ducts are able to adjust the urine osmolality. Okay, so let's talk about that in more detail. What the heck does that all mean, right? Okay, so the countercurrent multiplier, it uses energy to generate that osmotic gradient so that we can reabsorb more water and produce more concentrated urine. So I talked about this a little bit already, right? It gets saltier in the medulla as we move deeper into the medulla because of that osmolality. And this is why we keep reabsorbing more and more water as we move down the descending limb of the loop of Henle. Okay? So the more salt the ascending limb transports out into the interstitial fluid. Remember, part of these ions is going to be sodium and chloride, which makes salt. Okay? So the more salt that is transported out into the interstitial fluid, the more water is going to diffuse out of the descending limb. Okay? The more water that diffuses out of the descending limb, the more salty the filtrate inside of here becomes. Right, because we're losing water and we're going to leave behind those solutes like salt. So the ascending limb can then use that salty filtrate to keep raising the osmolality of the interstitial fluid in the medulla, okay? So it's more and more salty here, it can push out more and more salt, okay? Make it saltier, more water releases, okay? So there's always a difference of 200 milliosmol between the limbs of the nephron loop and between the ascending limb and the interstitial fluid, okay? And then this difference becomes multiplied along the length of the loop, okay? So from 300 to 1200, at the end we get a difference of 900 milliosmol, Okay, so it's just a continuing system, right? The more water that leaves, the more salty the medulla becomes. The more salty the medulla becomes, the more water that leaves, and it just kind of continues on and on like that. Okay. Okay, so the loop is going to concentrate the filtrate and then dilute it even more, right? So it gets concentrated by salt, and then it gets diluted by water. Okay? And again, it's just a loop that continues on. Okay? So how much fluid we intake is variable, right? Some days we drink a lot of water, some days maybe we don't drink so much water. It all depends on us and what we're doing, right? So, but we still need to maintain homeostasis in the body, right? We need water for lots of different chemical reactions within the body, okay? So to maintain homeostasis, we need to maintain the fluid volumes within specific limits, okay? So our urine concentration is going to vary with ADH, which I talked about a little bit already. That's antidiuretic hormone, okay? So if we intake a lot of fluids, we'll have very dilute urine of a high volume. So we'll pee out more and it'll be more dilute volume. It'll have more water compared to solutes. If we don't take in as much fluid, if we don't drink as much water, we will have concentrated urine with a low volume. Okay, so we won't pee as much and it's going to be concentrated. It's going to have a lot of solutes in it. Okay. So now that we have that osmotic gradient that we talked about, this can be used to help us form either diluted or concentrated urine. Okay? So if we didn't have that gradient, we wouldn't be able to raise our urine concentration above 300 milliosmol to conserve water. Okay? Okay, so if we're overhydrated, ADH production is going to decrease, okay? So our urine is going to be at about 100 milliosmol. If aldosterone is present, more ions can be removed, and this causes the water to dilute to about 50 milliosmol. Okay, so overhydration, we can get rid of more water because we have enough water being reabsorbed at these earlier stages, okay? And then more, in that case, if we're overhydrated, we're not going to reabsorb our water in the distal convoluted tubule and the collecting duct, right? So this won't happen, okay? If we're dehydrated, we're going to produce small volumes of concentrated urine, so lots of ADH, antidiuretic hormone, is going to be released, and urine is at about 1200 milliosmol. Okay. If we're severely dehydrated, then almost all of our water is going to be reabsorbed, about 99%, and then we're not going to pee as often, right? So a common sign of if someone can't talk, like a baby, if they're dehydrated, they're not having any pee diapers because they're reabsorbing all of the water they possibly have in the body, okay? So when dilute urine is being formed, the osmolarity in the tubule increases in the descending limb, decreases in the ascending limb, and then decreases even further in the collecting duct. Okay. Okay. So we talked about how this all happens. Okay. So if we are secreting ADH, antidiuretic hormone, the collecting ducts then become very permeable to water. Okay, so the tubular fluid is going to become concentrated. Okay, that movement of water is also going to carry urea into the medulla, which contributes even more to its osmolarity. Okay, so if we were so overhydrated we did not have any ADH being secreted, we would have a low osmolality of our extracellular fluids, low ADH release, so it's not being released from the posterior pituitary, less aquaporins, which are water channels in the collecting duct, and less water reabsorption happening in the collecting duct. So really no water reabsorption is going to happen in the collecting duct. So then we have a lot of water still in the filtrate here, so our urine is going to be dilute and it's going to be a large volume of urine. Okay, oppositely, if we're very dehydrated and we have lots of ADH being secreted, okay, there will be a high osmolality of the extracellular fluids. Lots of ADH will be released from the posterior pituitary. Lots of aquaporins will be found in the collecting duct, okay, and lots of water will be reabsorbed from the collecting duct and the distal convoluted tubule. So this is when we're dehydrated, right? That's what I wrote there. Okay, and then we would have a small volume of very concentrated urine, so less water in the urine, right? Okay, so how does urea help form that medullary gradient? So I mentioned that very quickly, right? So urea will enter the filtrate in the ascending thin limb of the nephron loop, okay, just via diffusion. Okay, the collecting duct is going to reabsorb water and leave urea behind in this case. And then deep in the medulla, the highly concentrated urea can leave the collecting duct and enter into the interstitial fluid of the medulla, okay? Then it can move back into the ascending limb, and it contributes to that high osmolality of the medulla. Okay? So, let's talk about some chemicals that can enhance our urinary output, make us pee more, okay? So ADH inhibitors, so this would be like alcohol, okay? So they inhibit ADH and cause us to pee more. Then we have sodium reabsorption inhibitors, which also helps water to be reabsorbed, okay? Or inhibits water reabsorption. Okay, so this is caffeine, drugs that are used for hypertension, or drugs that are used for edema, which is fluid collection in the interstitial fluid. Okay, so caffeine makes you pee a lot more as well, right? Okay. And back to our diabetic patient, right? So remember we said with our diabetic patient, there's not enough time for all that glucose that's found in the blood of the diabetic patient to be reabsorbed in the proximal convoluted tubule. So now the glucose is going to go into the filtrate, some of it, okay? So because of that high concentration of glucose, water is going to go along with the glucose. So it pulls water from the body along with the glucose, okay? So diabetics tend to have to pee a lot as well because they have a lot more water being pulled out of the body because of glucose also being pulled out of the body because of such a high concentration of glucose, okay? Okay, so how can we evaluate our kidneys' function? So urinalysis can be done. This is just a pee test, right? You pee in the cup and they can test for lots of different things within the urine, okay? So urinalysis tests for things like albumin, glucose, red blood cells, white blood cells, microbes, all different things that could be found in the urine, okay? All right, a homeostatic imbalance, chronic renal disease. This is where we have a glomerular filtration rate of less than 60 ml per minute for 3 months. Okay, chronic, right? It's happening over time. So in this case, filtrate formation decreases, nitrogenous wastes are going to accumulate in the blood, and the pH becomes acidic. Okay, so this is seen with people with hypertension, with diabetes mellitus. Renal failure, so this is even worse, right? This is a glomerular filtration rate less than 15 mils per minute, okay? So this causes uremia, which is an ionic and hormonal imbalance. It causes metabolic abnormalities and toxic molecules to accumulate. Okay. So treatment is dialysis or kidney transplant. Okay, so it's the normal chemical composition of urine. So 95% of it is going to be water and 5% solutes in a normally hydrated person. Okay. Nitrogenous wastes you can find in urine as well. So urea, this is caused from amino acids breaking down. This is the largest solute component of urine. Uric acid, this is caused from nucleic acid metabolism. And creatinine. Okay, so this is the metabolite of creatine phosphate. Okay, which is how we, one way that we can get energy, right? Creatine phosphate. Okay, other normal things found in urine would be like sodium, potassium. You're gonna have some of those ions found in the urine. Okay, but if we have too much of any of those things, or a component that we shouldn't find in urine, like blood proteins, any formed elements of blood, bile pigments, this could indicate something is wrong. Okay, so we'll talk about that in a few minutes. Let's first talk about what urine's characteristics should be. So urine should be clear. If it's cloudy, it can indicate a UTI, urinary tract infection. It should be a pale to a deep yellow from urochrome. This is a pigment from breakdown of hemoglobin. Okay, and then if we're dehydrated and the urine is very concentrated, it's going to be a much deeper yellow. If we're overhydrated, it's going to be almost closer to a clear color. Okay. Abnormal colors would be pink, brown, or smoky. So this can potentially be caused by foods or bile pigments, blood, or different drugs. Odor should be slightly aromatic when it's fresh. If it's not fresh, then it develops that strong ammonia odor because bacteria is metabolizing the urea, okay, and that causes the stronger ammonia smell. Okay, it can be altered by some drugs or vegetables, right? If you've eaten asparagus, it causes that strong odor in the urine, so that is fine and normal. Okay, or a disease can alter smell. So if people have diabetes, their urine tends to smell like more like acetone, okay, or have like a sweeter type smell. Okay, pH is slightly acidic, so a pH of around 6, but it can range from 4.5 to 8. Okay. If you have a more acidic diet, this can drop your pH. Or if you have an alkaline diet, a more basic diet, or if you're very sick, so you have prolonged vomiting or a UTI, this can cause an increase in the pH, so it can become more alkaline. Okay, and specific gravity, this is the ratio of the mass of the substance compared to the mass of an equal volume of water. Okay, so specific gravity of water is 1. So since urine is 95% water, it should be very close to 1. So it ranges from 1.001 to about 1.035. Okay, if it's different than that, if it's too high, then maybe there are, or too low, there maybe there are too many or too little solutes in the urine. Okay. Okay, so some abnormal constituents that you find in urine. Glucose, right, we've already talked about that. That can indicate diabetes. Okay, name of the condition is glycosuria. Proteins, name of condition would be proteinuria or albuminuria. Okay, this could be caused to pregnancy, causes more proteins to be found in the urine. Or if you're working out really hard, that can cause proteins to be in the urine. Okay. Or it can indicate glomerulonephritis, heart failure, or some sort of renal disease. Ketone bodies. This happens when you have untreated diabetes or if you're starving. Okay, so this is ketonuria. Hemoglobin, this is hemoglobinuria. This can be caused by lots of different things like burns or anemia. Bile pigments is known as bilirubinuria, right? Because the bile pigment is bilirubin. This can indicate some sort of liver disease. Erythrocytes, this is hematuria. This can be caused by bleeding in the urinary tract, okay, caused by different things like kidney stones or an infection maybe. And leukocytes, this is known as pyuria, and this can indicate a UTI, right? Because you have white blood cells coming to the site of a bacterial infection. okay? All right, so that's all the kidney and urine, okay? Now ureters. So ureters just transport urine from the renal pelvis to the bladder. So they do this via peristaltic waves, hydrostatic pressure, and gravity as well. Okay, there's no valve or anything. It just empties straight into the bladder. Okay, when the bladder is full, it compresses the opening and prevents backflow of urine back into the kidneys. Okay. Okay, so the ureters are also retroperitoneal, just like the kidneys. And they have 3 layers of the ureter wall: the mucosa, so this is made up of transitional epithelia; the muscularis, this is smooth muscle that contracts in response to stretch, so that helps to propel the urine into the bladder. Okay. Adventitia, this is the outer fibrous connective tissue of the ureter. Okay, the bladder, we talked about the bladder anatomy already, so I'm going to skip that, and the sphincters. Okay, and we talked about the male versus female urethra. So UTIs, urinary tract infections, these can be caused by improper toilet habits, like wiping back to front after defecating. Okay, remember that short urethra of the females much more easily allows bacteria to enter the urethra. Okay, so most UTIs will occur in sexually active women. Okay, so intercourse can drive bacteria from the vagina and external genital region toward the bladder. Okay, so those are UTIs. Urethritis, this is inflammation of the urethra, usually from a bacterial infection. Cystitis is inflammation of the bladder. Pyelitis or pyelonephritis is inflammation of the kidneys. We already talked about those. Okay, so symptoms can be painful urination, urgency to urinate, and having to urinate more frequently, fever, sometimes cloudy or urine with blood in it. Okay, if kidneys are involved, it can cause back pain as well, since those kidneys are retroperitoneal. Okay, so treatment, antibiotics can cure most UTIs. Micturition, this is just discharge of urine. It's the anatomical term for peeing. Okay. So there are 3 events that have to occur in micturition. 1, contraction of the detrusor muscle. This occurs via the autonomic nervous system. Then the internal urethral sphincter needs to be opened, also by the autonomic nervous system. And then the external urethral sphincter is opened by the somatic nervous system, because that one's under our conscious control. Remember, the somatic nervous system controls like our skeletal muscles. Okay. In infants, urination is a reflex. Okay, so when the bladder is distended or stretched, it activates the stretch receptors, and this causes an excitation of the parasympathetic neurons in the reflex center of the spinal cord, and this leads to contraction then of the detrusor muscles and opening of the internal sphincter. Okay. And then inhibition of the external sphincter that normally we would control ourselves relaxes that external sphincter, so that can open up as well. Okay, so those pontine control centers will mature between ages 2 and 3, so that's when you start the potty training process. Okay. So a couple other homeostatic imbalances: urinary incontinence in adults. This can be caused by weakened pelvic muscles. Okay, so overflow incontinence is when urine kind of dribbles out when the bladder overfills, and stress incontinence is caused by increased intra-abdominal pressure, and this forces urine through the external sphincter. Okay, so laughing causing sneezing can cause incontinence. So if you've had lots of kids, this can sometimes, if you've been pregnant a lot of times and pushed out a baby, this can weaken the pelvic muscles. So this happens a lot in like older women who have had a few kids. Okay, but you can work on strengthening the pelvic floor muscles in different ways. So it doesn't always happen. Okay, urinary retention. This is where the bladder is unable to get rid of urine or expel urine. This can happen after being under general anesthesia, or it can be caused by hypertrophy of the prostate in males. Okay, aging. So as we age, kidneys actually shrink in size, so we lose about 1/3 of their mass. And there's also a decrease in blood flow. Okay, so the glomerular vessels can become damaged or decrease in number. And there's also a decrease in filtration. So this whole system here just doesn't work as well because of that.